All right. Well, good afternoon, everyone. Welcome to today's Grand Rounds presentation for the Department of Family and Community Medicine at UT Health San Antonio. For CME credit, today's activity code is 1008-7629. It's also in the chat, just in case you need to reference it at any point during this session. Next slide, please. And just brief reminder, CME credits available via text message now. Here are the 2 steps that you must do to claim credit for today's session. Next slide, please. And just a friendly reminder, please mute your microphone once we've begun. Please be attentive to the presenter, be engaged in the session, and please complete the evaluation at the end. Our Grand Rounds sessions are in collaboration with the South Texas Regional Family Medicine Grand Rounds with our educational partner, the South Central Area Health Education Center. Our department's mission statement is the following: inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. If you need any copies of CME transcripts, these are the steps that you would follow for that information. And at the bottom of the screen, you will see that there is contact information for the CME office as well. Please have your AAFP ID ready for credit through them. This is a live activity and you are, it has been reviewed for up to 1 credit for this presentation. Go ahead and go to the next one. So today's presenters are Dr. Ravi and Dr. Hamilton-Bevil. They both have no financial relationships with ineligible companies to disclose. Go ahead.
All right. Hey, everybody. I am Haley, and thank you to Dr. Ravi for her help with this presentation as well. I'm going to try and make it a little bit exciting because it is a systematic review that we're going to be talking about today. But I think the information is super useful and very much is going to be applicable to all of our practices, whether we do outpatient medicine or inpatient medicine. So the title of the paper I'm going to be talking about today is Pharmacologic Therapies in Patients with Exacerbation of COPD, a systematic review with meta-analysis. So some of our learning objectives today are to summarize the various medications that can be used to treat COPD exacerbations and explain and compare their effectiveness. We're going to identify evidence that supports the use of antibiotics and systemic steroids for COPD exacerbations, no matter what setting they're in or what severity of exacerbation the patient has. We're going to discriminate amongst therapies that have insufficient evidence for successful treatment as well as adverse effects as well. Okay. So to get us kind of thinking about patients, we have a FHC patient here, Mr. B. He's a 72-year-old male with diabetes, hypertension, hyperlipidemia, depression, obesity. He's a former smoker. And he has COPD. He's coming into our clinic with about a week of worsening symptoms. He's concerned about his chronic cough that has gotten even worse. He's noticing more wheezing and much more phlegm, sputum production than usual. He also notes that the color of his phlegm has also changed to become more yellow. He finds himself getting short of breath with activity that usually doesn't bother him, like walking from room to room in his house. Despite using his prescribed inhalers as directed, his shortness of breath seems to only be getting worse. So I know it's not everybody's favorite thing to unmute and answer. So just kind of think to yourself, imagine, what else do you want to know? He's walking in. You're trying to make a judgment about what to do next. Whether to treat him outpatient, whether to hospitalize, and how to make that judgment call. So I definitely want to know vitals. His vitals are very stable. He is satting at 93% on room air, heart rate of 85. His blood pressure is normal, respiratory rate is 20, and he's afebrile. He looks pretty good. So maybe you're thinking you can try to treat him outpatient since he's not looking super, super sick. But he definitely needs treatment, you think. What are you going to do? Does someone with maybe a more mild outpatient case warrant antibiotics and steroids, or one or the other? I don't know if I would have been able to answer that very confidently before reading this paper. So that's what we're gonna try to put together today so we can feel confident in our treatment of COPD exacerbations, no matter where we are. All right.
Haley, could you comment on whether you want to do a chest x-ray here?
Ooh. I don't think it would change my personal management right now, but I think it is always good to get a chest x-ray to make sure they don't have like a lobar pneumonia or something going on as well. I didn't talk about imaging.
Yeah, so I don't think there's an absolute answer to this. I think you might want to base it partially on your exam and partially on, the story about whether they'd ever had any fever and anything that might sort of lead you to think they might have any a potential to have a pneumonia. So I would not have a terribly high threshold for getting a chest x-ray in a patient like this.
Right, I agree with Dr. Nato as well, as far as, you don't always have to get a chest x-ray. Just if there's fevers, or other clinical symptoms, if there's just crackles on one side, then I would get a chest x-ray. If not, I wouldn't.
Sorry, I got that turned around. You asked the questions. We're supposed to answer the questions. Sorry about that.
Thank you so much. That was a great question. All right, so before I go to the next slide, can somebody tell me some of the cardinal symptoms of a COPD exacerbation?
Increase in sputum.
Yes, there's one.
Worsening cough, worsening wheezes.
Worsening, what was that second part?
Worsening wheezing.
Yeah. Anything else?
Worsening shortness of breath.
Perfect. All right, let's go to the next one.
Since so many people have a pulse ox at home, they might have a change in their pulse ox as well.
Yes, they might. That's a very good point, especially post-COVID. We all have our trusty pulse ox, I think. So according to my searches, these are the main cardinal symptoms. We have, like somebody said, the increased sputum production, the increased purulence of sputum, and persistent dyspnea. So just overall worsening of all the COPD symptoms. But definitely those sputum changes are pretty key. Okay. So I think a lot of us are familiar with treating COPD exacerbations. Maybe you don't feel terribly uncomfortable about it. but certainly I hope we all feel a little more certain about some of the newer evidence for treating COPD exacerbations after this talk. Of course, some of our mainstays of treatment are antibiotics, systemic corticosteroids, and short-acting bronchodilators like albuterol, the SABAs. Other treatments that are frequently used or sometimes used are the short-acting muscarinic antagonists, the SAMAs, the LABAs, the inhaled corticosteroids, and then sometimes you'll see use of aminophylline, aminophyllines like theophylline, magnesium sulfate, mucolytics. Apparently people are using statins sometimes, and then 5-lipoxygenase inhibitors like xylutone. I'm not as familiar with that one. So today we're going to be kind of breaking down this systematic review. We're going to talk about how they evaluated treatments for effects on exacerbations, what were the health outcomes, what were adverse effects of these medications. Specifically, we're going to look at systemic antibiotics versus placebo or management without antibiotics. Systemic corticosteroids versus the same, either placebo or just no steroids. We're going to compare different antibiotics and corticosteroids a little bit. We'll talk about other types of drug interventions like those I just mentioned versus placebo or management without the drug. And then we're going to compare effectiveness of those drugs. Okay. So I don't know how many of y'all are familiar with systematic reviews. I certainly did not become familiar with the whole process myself until I was doing some work in public health, and I did the scut work of the systematic review, and it's a really, really intensive process. So when I read a study like this, I'm really impressed by their work. They go through all of their literature searches, their database searches. They described how they selected studies, like what were the inclusion criteria of the almost 9,000 studies they looked at, citations that they looked at. They narrowed it down to 68 randomized controlled trials with almost 11,000 participants. So that's pretty impressive. They limited it to adults, English studies published in English. They did not narrow it down based on setting. So it included both outpatient and inpatient cases, but it did exclude patients who were initially in the ICU or initially already ventilated at the time of the study. They had to include the interventions, at least one of the interventions that I previously mentioned, and look at the outcomes of interest, which we'll expand on in a second. They did independent review of the abstracts before going on to full text, of course. So that's kind of how the beginning of systematic review methods work. Are y'all able to hear me okay? It just said I had an unstable. So some of the outcome measures were clinical resolution of the exacerbation, failure of treatment in mild cases, repeated exacerbations, death, quality of life, hospital admissions, or need for intubation. Other outcome measures that they looked at included functional capacity, like timed walking tests and endurance tests, symptoms based on different scale criteria, lung function, as FEV1, adverse effects, and participant withdrawal for whatever reason. They looked at that as well. So let's see. As they're doing the data extraction, they characterize patients by all of their different characteristics and the types of studies. They looked at the different interventions, comparisons, outcomes at different time points. They did a risk of bias assessment using a Cochrane risk of bias tool. I had never heard of this. So I looked into it. It's an algorithm that breaks down different aspects of the trial and kind of the study quality, looks at the trial design, conduct, and reporting to give you more of an objective or quantifiable basis to judge what the risk of bias is, whether it's low, high, or if there's just some course, lots of statistical analysis. It was analyzed by, they followed the principle for intention to treat for their analyses. They grouped subgroups like by systemic antibiotics, systemic steroids, and the different severities of exacerbations. And then they also looked at the strength of evidence, and they used a tool for that as well to rate the strength of evidence as high, moderate, or low. So they did, a lot of in-depth analysis there. This is what their risk of bias data looked like here for like the ICU admission. That one is like, the highest risk of bias. And then, treatment failure, it noted that that one was pretty high risk of bias as well. So I was thinking, even though this is a major systematic review and it's a POEMS paper, so a very major set of evidence, it's still imperfect and bias is still a real factor because all of this is still done by humans. So they tried to minimize that and make it as transparent as possible. Also, funding, your source of funding for your study can definitely influence bias. However, for this one, it was funded by the Agency for Healthcare Research and Quality, and they had no impact on how the study was designed or any of the publishing or anything like that. So hopefully there's less bias in that way. All right. So results, what did they find with all these RCTs? They had several settings that they looked at: patients in outpatient, in the emergency room, hospital, and in a few studies, it wasn't really clear. In one study, they moved from outpatient to inpatient. So we've got a variety of, severities there in settings. Different studies had different intervention links and follow-ups. So you can see that varied from 4 to 56 days, and the follow-ups varied as well. 48 of the 68 RCTs, or the majority of them, reported adverse effects, but not all of the studies commented on this. However, none were statistically significant for any of the studies. Okay. So this is a crazy table. This is where they gave the overall evidence map of the interventions and the effectiveness outcomes. Can't really see it though, because it's microscopic. So here's half of it. I'm not really going to go into this here. I just wanted to show you kind of, what this paper's data looks like, the figures. And so if anybody has questions, I can always go back to that later. It goes over the individual studies in the comparisons made there. Okay, so continuing for our results. This is one of the main take-home slides right here. They looked at effectiveness of systemic antibiotics that they gave for a week to 10 days versus placebo or management without antibiotics. They looked at it in 7 studies, some of which were outpatient, others inpatient. They had, 2 mild, 3 that were mild to moderate, 2 moderate to severe, so a range of severities. They found that antibiotics were associated with increased resolution independent of the setting or severity. They noted that there was less treatment failure for mild exacerbations when antibiotics were given for 7 to 10 days. They also noted that symptoms improved for all groups in the patients that received systemic antibiotics. The studies of treatment failure were not done in moderate or severe cases. Those were only done for mild cases, because I was a little bit confused and concerned about how someone would do treatment failure, but it was just 2 studies. And let's see what else. At the end of the intervention, they noted these results. So that was pretty, they were pretty confident that antibiotics are helpful, and we'll continue to look at that. They also looked at effectiveness of systemic corticosteroids versus placebo or management without steroids. 9 studies looked at this in all of those different types of settings and the full range of severities. They noted that systemically administered corticosteroids were associated with less treatment failure, independent of the setting or severity, similarly to the antibiotics as well. They noted reduced dyspnea as a symptom and increased FEV1 in a few studies. However, they didn't note a statistically significant number of adverse effects for the antibiotics group. However, for the studies that looked at systemic corticosteroids, there was a significantly greater total and endocrine related number of adverse events. So that is something we will also cover. Let's see. There was no statistically significant change in any of the other outcomes though, like death, hospital admission, repeat exacerbations, or intubation. And these findings were the findings where systemic corticosteroids were helpful in this slide. That was found for all pooled studies and also the mild subgroup. So they looked at comparing the different types of medications, the different drug types, the way that they were delivered, and how long they were administered. So this was looked at in 34 of the RCTs with almost 8,000 or 7,000 patients. So levofloxacin reduced repeat exacerbation at 3 months. And that was versus, I can't say that, culifloxacin. I don't think we use that much here, but levofloxacin seemed to be the superior drug in their trial. These are all individual studies as well. So that was one RCT. Another one is that telithromycin was associated with less adverse effects than augmentin or amoxicillin clavulanic acid. Meropenem was associated with less adverse events than imipenem plus celastin, and that was done in inpatient patients. They also found that inhaled budesonide was associated with fewer endocrine side effects and adverse events than the IV methylprednisolone, but they didn't note any differences in outcomes. So that's pretty significant as well. And that was in hospitalized patients with moderate to severe exacerbations. Okay. All right. So whenever they compared the durations, they compared 3 versus 10 days, 5 versus 14, and 2 weeks versus 8 weeks. These were done for inpatients with moderate to severe exacerbations. The only significant difference that they found was that there was a lower FEV1 for the 3-day group than the 10-day group. But importantly, they also noted that 5 days of steroid treatment was not inferior to 14 days. So that kind of tells us that shorter duration can be more advantageous and might be a better choice based on this evidence. Okay, so some of the other medications that are frequently used or sometimes used for COPD exacerbations were also looked at. There were 3 RCTs that looked at the IV aminophyllines like theophylline. They didn't find any significant association with any effectiveness outcome for those medications. Excuse me. They also had higher adverse events and GI-related adverse events. So that did not seem to be very helpful based on this evidence of those 3 studies. For IV magnesium that was given for 1 to 4 days in 5 RCTs, they noted that there was an association with increased lung function or FEV1 and not really any adverse effects. So that one didn't seem to cause any harm. They did look at one RCT, one of the 5 was nebulized mag sulfate as well. And then looking at mucolytics, I hear a lot of patients, or I don't know, I hear a lot of patients ask for mucomist, which is NAC and acetylcysteine. In the 4 studies that were examined in this paper, they found that it was not associated with any effectiveness outcome for any severity of COPD exacerbation. However, no significant adverse effects either. And that was done in outpatient and in hospitalized patients. All 4 of those studies were done in different settings. So that applies to a variety of our patients as well. Erdosine was given for 10 days, and that was associated with reduced repeat exacerbations at the 2-month follow-up. Also some reduced symptoms and a higher lung function. They only did 1 study with this medication. It was inpatient in moderate to severe severity of exacerbation. And then some anti-inflammatory medications were looked at as well. Simvastatin for 14 days was associated with an increased FEV1, and then pioxyluton was associated with an increased absolute FEV1 as well. There were not significant adverse effects from these medications. All right. So of the inhaled medications, they started looking at the route of delivery of the drugs. For inhaled medications, the inhaled corticosteroids were associated with higher lung function. The inhaled corticosteroids plus a short-acting was associated with increased FEV1 as well. And there were not significant differences found for the rest of the inhaled medications, all those different combinations of SAMA versus ASABA, and then combining them, they just didn't find significant differences there. So really the only helpful ones that they found were the inhaled corticosteroids, plus or minus the short-acting beta agonist. So for our discussion kind of our main points of this paper, both antibiotics and systemic corticosteroids were associated with lower rates of treatment failure, independent of how bad their exacerbation was. Didn't matter if it was mild or severe, it was helpful to get antibiotics and corticosteroids. It improved their dyspnea as well. For all settings, even for patients in the mild outpatient setting, it was beneficial as well to give both antibiotics and steroids. This also had evidence for shorter duration of systemic corticosteroids, so that even though we should probably give it to everybody, we shouldn't give it to them for a really long time. Less is more. They showed that 5 days was not inferior to 2 weeks. And then they also found that inhaled corticosteroids were not inferior to systemic corticosteroids. and could have less side effects since it's not systemic. However, they didn't find enough evidence for an antibiotic of choice or a mode of delivery of choice or the ideal length of time for treatment. We didn't get enough evidence from this systematic review to kind of come up with those answers, but we did get some answers. So it also didn't support use of any of the other pharmacologic treatments like mucomist or statins or any of those others that I mentioned that are outlined here. Even though they did kind of help with lung function, they didn't help with like patient-centered outcomes of like actually getting over your exacerbation or having repeat exacerbations. It just made the numbers look better and maybe symptoms in the moment, but end result was not affected by use of these drugs. Okay, and then immunophilines were not helpful for sure. They also noted that inhaled budesonide was equally effective to the IV methylprednisolone without as many adverse effects. So thinking about Mr. B and FHD again, what do you think about what you would do for him? I think I have a pretty clear answer now, and I definitely wouldn't have felt as confident before about whether he would earn himself both a treatment with steroids and antibiotics. But based off of this study, seems like he should probably get both.
Would you admit it?
Dr. Nato?
I was going to ask if you would admit it. This is treat, outpatient, or hospitalized?
I would treat him outpatient based off of his, reassuring physical exam and vitals. I would try to keep him outpatient, but still give him the full treatment with some antibiotics and some steroids, maybe also some inhaled corticosteroids, which is the same thing I would give to somebody if I sent him to the hospital. I went through that a lot faster than I thought I would.
So maybe Dr. Robbie had some comments. Otherwise, I just had a couple of comments. So I was noticing that on the list of people attending the conference, there's some fairly mature physicians. So they might remember back into the 80s, right? When Reagan was president, this was a much more common chronic disease, right? That's because people smoked more then. So we lament that we can't get our patients to quit smoking, but there actually is less smoking now than then. And so this was like the major, or certainly one of the major chronic diseases that led to admission back then. Things were a little different then. We use a lot more aminophylline then, which has fallen out of favor, as was described here, because as Haley points out, it's really not that effective, especially for the long-term benefit, and it's got a narrow therapeutic window, so you get a lot of side effects. It had to follow levels, and it was a little bit tricky. What's not changed is use of steroids is similar. We had even way back then, we had the sense that the things that were helping the most were the things that were discussed here, 40 years later, like the steroids and the inhaled treatments, right? So that's really stood up over time, and some of the less effective things have actually fallen away. The point about the steroids, I think you could treat this patient with outpatient steroids, maybe some once a day prednisone or something like that. If you go for the 5 days as Haley recommended, you don't need to taper it. And so it's pretty easy for the patient to take that part of it. So And then, of course, you keep the door open because patients can always get worse. But a lot of times a day after you start the steroids, they're significantly better. I did mention early in the talk that a lot of people have pulse oxes at home now, right? Well, back when Reagan was president, there wasn't, a pulse ox was not a thing, right? So we did a lot of blood gases instead of what you guys are doing now, which is the pulse ox VBG, right? And so that was much more common. I mean, you might do a blood gas to see if they're get a better sense of whether they're retaining CO2, but then it was a lot more blood gases, which are, have some side effects and they're significantly more painful than other blood draws. And then lastly, I was going to point out there was a board question given. I think a not unusual board question talks about treatment of bronchitis. And the answer is generally you don't treat bronchitis with antibiotics except in COPD patients, right? And then that is the right answer, as Haley pointed out. So I think that's a pretty good thing to keep in mind. Maybe I'm a little late on that because the third years, most of them have taken their boards, but the second and first year still have that coming up.
Thank you, Dr. Nato. Dr. Katendall put something in the chat about how they did this data, I guess, extraction. So he asked in their search for studies, did they look for unpublished studies? As far as I know, they did look. It says here, let's see. So they looked at ahead of print and in process, but I don't know how many of those they actually used. I have to look into that. But it was included in their search.
Yeah, they looked at non-index citations as well. Yeah, they did a pretty extensive search.
One thing I found kind of interesting was one of the, I guess you have it in this slide, it says inhaled budesonide is equally effective to IV methylprednisolone, right? So is it really that effective? I have to look at those individual studies to see what's going on with that.
Dr. Robbie, this is Aurelia. Along those lines, just want to make a comment about making sure that our patients really know how to use their inhalers correctly, because when they say that inhalers are, usually it's the inhaler used to be compared to the nebulized products, and so those are equally effective, but only if the patient is using the inhalers correctly. So, when you're evaluating a patient for an exacerbation, you did mention that he was having trouble despite taking his inhalers, but my question is he really using them correctly? So I always make sure. And if you don't know, because there are a lot of different devices, I always recommend this website that is use-inhalers.com. And it has videos of how to use all these inhalers correctly that you can just show to the patient. So use-inhalers.com. That's all.
Thank you so much, Dr. Bazaldua.
Was it just the standard doses of inhaled corticosteroids used?
I believe so. Yes, I think they were just the standard doses. Anything else?
Does anyone else have any other questions or comments?
Thank you all very much.
No? Okay, well, thank you so
Well,
much.
I agree with the outpatient treatment, but of course, close follow-up.
Absolutely. Absolutely. Thank you.
Regina, are you going to send the link for feedback? Is that how that's going to work?
Yes, I'll put it in the chat right this second. Give me 1 second.
One way to thank Dr. Hamilton for such a nice talk is to fill out the feedback form.
Absolutely.
That would be great. Thank you so much. Alrighty.
Well, thank you so much, Dr. Hamilton. I will get the link into the chat for the evaluation. Thank you, everybody, for joining us this afternoon. We really appreciate the engagement, the comments, and the questions. I will
Thank you.
stop the recording also.